This presentation, brought to you by Connor, Tom, Lucas, Luke and Ella, will cover an overview of spinal cord injury.
We would like to show our acknowledgement of country. On behalf of those present, I acknowledge the Wurundjeri people of the Kulin Nation, who are the traditional custodians of the land on which we now meet. I pay my respects to their elders, past, present and emerging. I also pay my respect to all Aboriginal and Torres Strait Islanders, people of Australia, and hope that the path towards reconciliation continues to be shared and embraced. A spinal cord injury is the occurrence of an acute traumatic lesion of the neural elements in the spinal cord, resulting in any degree of sensory deficit, motor deficit, or neurogenic deficit of bowel or bladder function, either transient or persistent. Although the injury is not as common as other injuries, the physical and psychosocial consequences tend to have a profound impact on the individual. Globally, between 250,000 and 500,000 people suffer from an SCI with an annual global incidence of 40 to 80 cases per million. Roughly 90% of these cases are due to traumatic causes, however there has recently been a growth of non-traumatic spinal cord injury. In 2013, the incidence rate reported per million in America, Canada, Western Europe and Australia were 39, 35, 16 and 15 respectively. The World Health Organization states that males are most at risk in young adulthood and older age, whilst females are most at risk in adolescent and older age. The male to female ratio of individuals suffering SCI is at least 2 to 1 respectively. At a national level, it was reported that males accounted for 80% of traumatic spinal cord injuries between 2016 to 17. The etiology of SCI can be categorized into traumatic and non-traumatic injuries. Traumatic SCI is a term used to describe instances where the cause of injury was external to the person, whilst non-traumatic SCI is a term used to describe instances where the cause of injury was the disease. The Australian Institute of Health and Welfare released a report summarising the most common causes contributing to spinal cord injuries between 2016 to 17. From Table 4.1, it is evident that the large majority of individuals with an SCI were male. Table 4.2 displays the mechanisms of injury of all traumatic SCI cases aged 15 and over. The two largest contributors to SCIs are land transport crashes and falls, each contributing 39% each. Land transport crashes could be further categorized into two groups: motor vehicle occupant or unprotected land transport user. The common crash events to occur for the motor vehicle occupant group included vehicle rollover or impact with a roadside hazard, ejection from the vehicle, and impact with another motor vehicle. Similarly, the unprotected land transport users included motorcyclists, pedestrians, pedal cyclists, and quad bike riders sustaining SCIs after collision with roadside hazards or other motor vehicles. Falls are also categorized into two groups: low falls, which is a height less than 1 meter, or high falls, which is from a height greater than 1 meter. Common accidents that were classified as high fall included falling from a ladder, falling from the roof, and falling through a roof or skylight. Less common causes of SCI included shallow water-related events such as diving or jumping into water, such as pools, shallow surf, or off a jetty. Heavy falling objects, horse-related activities, which included falling from a horse or along with a horse that appeared to trip and fall, and trauma during Australian rules football and rugby. The consequences of the listed events resulted in damage to the spinal cord and contents, resulting in an SCI upon impact.
The pathophysiology of an SCI has two phases: a primary phase and a secondary phase. The primary phase involves the initial mechanical injury, whereby force is directly applied and damages the white matter of the spinal cord. The primary phase is further characterized through four distinct injury mechanisms: impact plus compression, which typically occurs through burst fractures whereby bony fragments or a fracture compresses a spinal cord, an example seen on the screen. Impact alone with transient compression, observed less frequently but commonly occurs through hyperextension injuries seen in the initial phase of a whiplash injury. Distraction injuries. This occurs when two adjacent vertebrae are pulled apart, causing the spinal column to stretch and tear in the axial plane. Laceration and transection injuries, which occurs through severe dislocations or sharp bone fragment dislocations, which can vary from minor injuries to complete transections. Notably, however, most spinal cord injuries do not completely transect the spinal cord. Moreover, during and after the primary phase, a more insidious secondary phase begins. The secondary injury phase begins within minutes following the initial primary injury, continuing for several days, weeks, months, and sometimes years. This phase is characterized by a series of cellular, molecular, and biochemical processes, with some aiding in the neurological recovery, whilst a significant amount of them result in further disruption. The literature on the secondary phase of the pathophysiology of an SCI has characterized these processes into three phases: the acute phase, the subacute phase, and the chronic phase. The acute phase begins immediately at the time of the spinal cord injury, lasting up to 72 hours. The key events occurring in the acute phase are vascular ischemia and hypoxia, which sees disruption of spinal cord vascular supply. Ischemia causes a lack of energy by providing unsatisfactory transport of glucose and oxygen to injured tissues, conversely shifting the site of injury to a state of anaerobic respiration, which instigates the process of necrotic cell death and tissue destruction. The inflammatory response initiates the release of pro-inflammatory cytokines TNF-A and interleukin-1, which induces endothelial damage, promoting the influx of macrophages, microglia, lymphocytes, and neutrophils to the injury site, which engulf debris, usually promoting regeneration. However, the ischemic environment present due to the trauma can result in a failure to remove the debris, resulting in further damage. The combination of direct cellular damage and ischemia results in ionic imbalance and triggers a loss of regulation of extracellular concentrations of sodium, calcium, and glutamate. This leads to excessive production of free radicals and induces a state of glutamate excitotoxicity. This state results in neuronal degeneration and more cell membrane disruption, which culminates in necrotic cell death. Days to weeks following the injury, the subacute phase commences. The first key event in the subacute phase is Wallerian degeneration. Seen on the left of me, this process is induced through degeneration of oligodendrocytes, which leads to chronic demyelination of the myelin sheath. The myelin sheath is the insulating layer around nerves which facilitate electrical impulses along axonal nerve fibers. With this affected, nerve signals cannot travel as fast and may leak out in the damaged myelin. This can cause various CNS disorders and impair an array of bodily functions such as vision, reflexes, movement and sensation. A second key event is seen on the right of me, Glial scar formation. Literature has shown that Glial scar formation possesses advantageous and harmful effects, as it acts to prevent further uncontrolled tissue damage by protecting the lesion. However, it subsequently prevents the growth of new neurons. Proceeding into months and years following the spinal cord injury, local disruption of CNS connections results in chronic changes, known as the chronic phase of the secondary injury. This phase is characterized by segmental sprouting of axons, plasticity, cyst formation, progressive axonal dieback, maturation of glial scar, leading to alterations in neuronal excitability. Collectively, these events result in clinical manifestations of spasticity, dysreflexia, and further neurological dysfunction or growth, although the severity of the injury will dictate the proliferation and extent of these processes.
Spinal cord injury occurs when something interferes with the function or structure of the cord. This can include consequences of a medical illness or trauma affecting the nerves. The effects of spinal cord injuries vary depending on the severity and location of the damage to the spinal cord. In general, the higher in the spinal cord an injury occurs, the more function, sensation, and internal body functions will be affected. Types of spinal cord injury can be classified as either complete or incomplete, and further subclassified based on physical presentations and etiology. Complete spinal cord injuries occur when the spinal cord is fully compressed or severed, completely eliminating the brain's ability to send signals below the point of injury, whereby there is no motor or sensory function below the level of injury. Both sides of the body are equally affected. Symptoms of complete spinal cord injury occur 6 to 8 weeks after spinal shock has worn off. Complete spinal cord injury will present as either tetraplegia, paraplegia, triplegia, or hemiplegia. Tetraplegia is a paralysis which is caused by an injury of the cervical spinal cord. Patients with tetraplegia have different clinical presentations depending on the level of their injury. In general, all patients have motor and sensory deficits in arms, trunk, and legs. In the case of a high tetraplegic lesion above C3, it is possible that the patient experiences a locked-in syndrome, meaning that they are aware of everything, but there is little to no communication possible. Injuries that occur above level C4 often result in respiratory deficiency. Triplegia is paralysis of both legs and often one arm, and is likely caused by injury in the cervical spinal cord. Thoracic level injuries are less common because of the protection given by the rib cage. Injuries to the thoracic and lumbar nerves are both likely to cause paraplegia with loss of function of the hips and legs and loss of bladder and bowel control, whilst thoracic nerve injury is likely to also affect muscles of the trunk and back. Sacral level injuries can cause weakness or paralysis of the hips and legs and often causes loss of bladder control. Incomplete spinal cord injuries occur when the cord is compressed or injured, not fully severed, but the brain's ability to send signals below the site of the injury is not completely removed. This injury encompasses any spinal cord injury in which a person retains some feeling and or function below the injury site in one or more areas of the body. The nature of these injuries varies greatly. For example, an incomplete spinal cord injury may be so mild that there is barely any muscle weakness or other signs that an injury has occurred, or it can be so severe that it results in a person having symptoms similar to a complete spinal cord injury. Listed are 6 of the most common incomplete spinal cord injury syndromes. In contrast to a complete spinal cord injury, lesions only affect part of the cord and patients present with a dissociated sensory loss. Acute and subacute rehabilitation of spinal cord injury begins with the admission to hospital and stabilisation of the patient's neurological state. This is often a 6 to 12 week bed period. The aim of rehabilitation in this period is to prevent complications which may occur in the long term. Passive exercises should be done intensively to resolve contractures, muscle atrophy, and pain during the acute period of hospitalisation in patients with complete injury. In patients with paraplegia, the most important point is strengthening the upper extremities to a maximal level in the acute period of rehabilitation. Range of motion exercises prevent contractures and maintain functional capacity. Muscles are flaccid during the period of spinal shock and become spastic thereafter. Exercises can be done more easily with flaccid muscles. Breathing exercises should also be carried out in order to prevent pulmonary function decline. During the chronic rehabilitation of spinal cord injury, the most important goal is realisation of the independent mobilisation for both complete and incomplete paraplegic patients. The most important expectations in the chronic phase are to return home, ensuring maximum independence related to the level of the patient's injury and integration of the patient to society, also teaching families the importance of their role.
As previously discussed, SCI can be a debilitating condition, with implications not only restricted to bodily impairment, but also affecting the individual person as a whole. The WHO-ICF is a biopsychosocial framework which can aid in understanding a patient's impairments, activity limitations, participation restrictions, and the influence of environmental and personal factors and how these domains interact on a person's health and well-being. This information is highly relevant for physiotherapists, providing a holistic insight into the problems faced by those following SCI so that a comprehensive assessment can be undertaken, whereby appropriate goals can be set and interventions administered. If we take the WHO-ICF model, with SCI as a health condition under investigation, each of the subsequent domains and correlating problems will be dependent upon the neurological level of injury and the severity of damage to the spinal cord. As Lucas previously touched on, individuals with complete injury or injury sustained higher on the spinal cord generally display a greater degree of impairment than those with incomplete injury or those sustained to the lower spinal cord region. Therefore, it is important to note that patient presentation following SCI is varied, with these two factors highly influential in the patient's presenting problems. This diagram presents an example of how the WHO-ICF can be used to unpack the functional, activity and participatory problems associated with SCI and how environmental and personal factors interact with these domains. It should be mentioned that these examples provide a general overview of presenting problems, which are not universal to each individual. If we firstly take the functional impairments following SCI, deficits in sensory motor function is the most commonly reported complication. Deficits in sensory function is associated with a reduced sensitivity to light touch, pressure, proprioception, temperature and pain. Furthermore, deficits in motor control often result in changes in muscle tone, which can be characterized by increased or decreased tone, the most common of the two being spasticity. Other common functional impairments include loss of bowel and bladder control, with patients finding difficulty with urination and defecation, changes in sexual function and fertility, deficits in respiration, often reported as difficulties with breathing, coughing, or clearing secretions from the lungs, which can also result in speech difficulty, pain or stinging sensations, emotional functions such as depression and anxiety, and finally, as suggested in the name, the spinal cord is the most affected body structure following SCI, giving rise to the functional impairments as just mentioned. If we now take activity limitations, these are largely dependent on whether the individual sustains a complete or incomplete injury and the level of spinal cord injury. Despite this, individuals commonly report limitations in personal activities of daily living, such as bathing, toileting, dressing and care. Various mobility tasks, such as transferring, mobilizing and changing body positions, as well as limited hand and arm use, which impacts on an individual's ability to independently eat and drink, most commonly seen in tetraplegic patients. Moving on to participation, which refers to actions in a context such as involvement in life situations and roles. The most commonly reported limitation is the inability of patients to return to their pre-morbid level of study or work, alongside a reduced participation in sport and hobbies. This can be due to functional limitations such as loss of motor control, especially relevant for labour-intensive or physical work, or psychological factors such as reduced motivation or depression. If we now take the contextual environmental factors which influence each of these domains, patients commonly report public transport, public and private building design, the education system, mobility aids such as wheelchairs, and the attitudes and support of their immediate family being highly influential in the overall functioning and well-being. Similarly, personal factors such as social status, motivation, behavioural factors, and receiving insight on prognosis are reported as to have a high degree of influence on the individual and each of the functional, activity, and participatory domains of the WHO-ICF. In summary, the WHO-ICF provides a comprehensive understanding of how SCI influences the various domains of life following diagnosis, ultimately facilitating a person-centred approach to care to optimise the well-being of patients in their rehabilitation.
The Spinal Cord Independence Measure 3 aims to objectively assess a patient's ability to perform functional tasks after suffering from a spinal cord injury. This assessment aims to guide practitioners when implementing treatment and developing patient-centered goals, and provides clinicians and patients with a clear understanding of the patient's level of independence. The SCIM3 was developed in 2002 and is based on a clear need for objective evidence-based assessment of patients who have suffered a spinal cord injury. The outcomes assessed on the SCIM3 indicate the patient's level of function and independence, with scores recorded between 0 and 100. A score of 0 indicates maximum assistance and a score of 100 indicates full independence. The SCIM3 contains 19 tasks organised into 3 subscales, these being self-care, respiration and sphincter management, and mobility, with assessment performed via an interview or observation. This form of assessment should be considered as an achievement whereby the patient with spinal cord injuries are assessed on successfully completing tasks of daily living. The version 3 of the SCIM3 has become one of the most frequently used assessment tools in the spinal cord injured population, with a number of outcome measures identified, and these can be seen on the slides. The implementation of the SCIM3 assessment tool requires minimal staff burden and requires only 30 to 45 minutes. This tool is strongly recommended to be used as an additional and discharge assessment and should be performed within 72 hours of their admission and within 72 hours of their discharge. The date of assessment, mechanism of injury, the level of injury and the deficits of the injury are initially recorded on the top of the assessment form. The patient is then observed or interviewed on their ability to complete a number of tasks, with each subcategory scored out of 3. A 0 score indicates full assistance and 3 indicates independence with that task. The score for each subscale is then calculated and an overall score divided by 100. A full outline of this tool is provided in the e-resources slide, with the subscales outlined in greater detail. The SCIM3 has been described as the ideal measure for those with spinal cord injuries due to the strong psychometric properties and observable nature of the tool. This tool is the only assessment that is strongly recommended and endorsed by the international community for use with spinal cord injured patients. The subcategories in the SCIM3 have been validated as a strong prediction of patients' future independence. An independent study by Itovich et al. 2018 assessed the reliability and validity of the SCIM3 and found the ICC values were above 0.94 with good inter-rater reliability when used as an observational tool. Blumstein et al. 2011 implemented the SCIM3 to assess a total of 261 spinal cord injured patients with either tetraplegia or paraplegia. They found favourable psychometric properties with total agreement between raters and high coefficient and ICC values. The internal consistency was good and with a consistently high correlation with the FIM or functional independence measure, with a greater responsiveness to change observed. The SCIM3 is cost effective and doesn't require clinical experience to achieve valid and reliable outcomes when used as an observational means. The outcomes from this tool should be considered a vital part of spinal cord patients' journeys, with results from the assessment shown to improve patient-centered and functional outcomes with improved patient education and compliance. Ackerman et al. 2010 reported a flaw effect specific to the level of C-spine injury in 13 of the 19 assessment subgroups. It is suggested that due to the significant impact such a high lesion has on function, patients are unlikely to make any significant improvements from their baseline level by the time they discharge. They also found a ceiling effect present in T-spine lesion patients due to the low baseline function at admission, which is followed by a rapid progression. It is suggested that due to the functioning upper limb results in significant change between baseline and discharge measures. Mulcahy et al. 2017 further identified a ceiling effect present in the self-care and in-room mobility subscales, particularly in younger population spinal cord injured patients. Itovich 2018 further highlighted the low to moderate outcomes when completed as an interview process, with results varying significantly. There was poor intralater and interrater reliability between interviews and when comparing interviews to observational assessment, resulting in frequent inaccurate outcomes. Anderson et al. 2011 highlighted discrepancies in the language and understanding of the terms requires partial assistance and distinguishing the means of this, leading to significant differences in the understanding of the terms between raters. They further suggested that rating patient independence appears inadequate, as patients who require max assistance would score the same as a patient who requires hands-off assistance, yet the patient's independence is significantly different.
Spinal Cord Injury Australia, SCIA.org, is a tremendous online resource that provides patient education resources on health and wellbeing, accessibility, services, statistics and reports on SCI, and has an online forum to discuss everyday topics related to it. SCIA is strengthened by the wide array of resources it provides, not only assisting patients who have sustained an SCI and understanding their condition, but goes into depth on how to live with it. However, SCIA is limited by the potential application of its services to rural areas. Specifically, SCIA offers an array of educational resources about the services they provide. However, to administer them, such as strength and conditioning, it requires access to a clinic, which are primarily based in metro areas of New South Wales and Victoria, therefore presenting a problem for people who have sustained an SCI in rural areas. In regards to PhysiTrack, there is no reason to believe that a neurologically intact muscle of a person with an SCI would respond to strength training any differently than the muscles of an able-bodied person. Therefore, the use of PhysiTrack may be a reliable resource for physiotherapists looking to implement physical activity programs for people with disabilities. In 2019, Benell et al. Typified how PhysiTrack, a web-based exercise programming system, improved home exercise adherence and confidence in the ability to undertake exercise. Not only provides a useful resource for physiotherapists to tailor a suitable program for a patient, but also provides educational resources for the patient to enhance their understanding. However, PhysiTrack does not provide a library of exercises which cater to specific spinal cord injuries. Therefore, physiotherapists must critically reason implementing an exercise demonstrated on PhysiTrack. To address the lack of transferability, PhysiTrack, Physiotherapy Exercises is a website and app that entails over 1,000 unique exercises that are being put together specifically to help patients with SCI. It allows physiotherapists to cater to all ages and different conditions. However, with no video tutorials, it may present difficulties for physiotherapists and patients to obtain information from. Moreover, SCI management presents itself as a complex challenge for healthcare professionals requiring professional development opportunities to maximise the quality of life for those living with SCI. This is a challenge for low-resource countries and those in rural areas. To address this, elearnsci.org, a web-based resource, was developed, aimed to increase the understanding, skills and knowledge about the management of SCI in a cost-effective way, ensuring access globally. Conversely, like other e-learning resources, elearnsci.org cannot replace the traditional learning methods of hands-on learning. Without this incorporation, practitioners may fail to understand the required needs of basic SCI management. To conclude, we hope you found this weekly in-service program informative and now have a better understanding on the etiology, the pathophysiology, the forms and stages, presenting problems, outcome measures, and resources related to spinal cord injuries. Thank you.